off-label use when we know that every single pediatric medication that is out there, with perhaps the exception of antibiotics, is used in an off-label fashion because there are very few studies done on pediatric patients to give that specific indication. So beginning to look at the appropriate use clause that exists in this PharmaCare pamphlet, again, to me indicates significant bureaucratic government overreach and interference with the independent practice of medicine. And, certainly we've seen it, I've experienced it before in medical practice where people who have not even examined a particular patient will want to argue with the physician about the diagnosis, that from afar, from a referee's chair at a tennis match, they would like to say, hey, this is not correct, that's not the diagnosis, it's not what should be happening, et cetera, when oftentimes it's somebody who has had a significant and long-term relationship with a patient with multiple medical trials and multiple consultations for a diagnosis. So as I would suggest, looking further down the road, and I'll be happy to repeat these comments when that time comes, but I wanted to get them on the record because it's very likely we will not get to those amendments, and these amendments will be rammed through on a vote without any significant consideration by this committee, much the way the rest of this bill has been, which on behalf of Canadians is a travesty. So, Chair, if there's no other ideas, I'm certainly happy to cede the floor and move on to a vote with respect to this particular amendment.
Well, thank you, Mr. Chair. And I'll note that the Conservatives have allowed one amendment to be voted on in 3 hours. That's thousands and thousands of dollars of committee time that has been devoted to the study. And the Conservatives filibuster, blocking this legislation as they have since February 29th, has meant that Canadian taxpayers, folks that are working hard, trying to make ends meet, have seen thousands of their tax dollars going into a filibuster, blocking legislation that is actually going to help people. I do want to address the national bulk purchasing strategy because it is true that Canadians pay more, and they pay more because of Conservative government decisions to extend patent protection. It was a beautiful sweetheart deal by a former Conservative government that extended patent protection so that Canadians pay unbelievably high drug prices. And it was Conservatives that caused that. And instead of saying, gee, we're sorry, Canada, we apologize for everything we've done to wreck your access to medication, we have Conservatives filibustering the next step, which is actually having a national bulk purchasing strategy that covers, through universal single-payer pharmacare, allows us to bring the cost of those drugs down. New Zealand did the same thing, Mr. Chair, and I know you're aware. Costs of some drugs went down by 90%. 90%. So not only does pharmacare in this bill, C-64, enhance Canadians' ability to access medication, diabetes medication, contraceptive medication and devices, but what it also does is by putting in place the national bulk purchasing strategy allows us to start meeting what other countries have already found, which is rather than just paying massive prices and extending patent protection to the pharmaceutical industry with the huge costs that has entailed. Now, it's made huge profits and lobbyists are happy. But instead, having a national drug purchasing policy will allow us to follow the lead of countries like New Zealand that have reduced the cost by 90%. Now, what this Conservative amendment, CPC 9, proposes to do is actually stop that, freeze it in place. Don't allow the bill to move further so that we can have in place a national drug purchasing strategy that goes beyond diabetes and beyond contraceptive. I oppose this. It's been 3 hours. Conservatives have allowed one amendment to come to a vote. I wish they would stop doing this, as it's not in the interests of their constituents or any Canadians for them to continue, as they have since February 29th, in blocking this legislation.
Ms. Goodrich, please.
Thank you, Mr. Chair. It's worth noting that Mr. Julian has found the need to interject at every available opportunity and continues to mislead Canadians, saying that it's been 3 hours when the reality is this meeting got to quite a late start, and so it's been less than 2.5 hours. But that falls into a space of semantics. I really get frustrated when they continually try and say this is a pharmacare bill when the entire guise of this is a creation of looking at two separate categories of pharmaceuticals. It's been mentioned many times in this meeting that heart pills aren't included. A variety of medication isn't included, and so it is not, in fact, pharmacare. Perhaps at very best, and this is being overly generous, it is a very small step towards pharmacare, but the reality is it's not. It's a pamphlet that agrees to certain categories to possibly at one day maybe look into creating something, but it really is just a way for the Liberals to get the votes so they can do whatever they want, act like they're in a majority government, and have the NDP hold the bag all the way along, tanking both of their polls in the process. And so this is something that Canadians need to hear very clearly. And if they were so proud of this bill and they thought this was so wonderful, they would have actually allowed a little bit more time to have these kinds of conversations. The fact that we were hearing from witnesses, and while we were hearing from witnesses, which is where we're in theory supposed to get some of the amendments, only like midway through listening to the witnesses on Friday, the due date was the due time for having the amendments in. So it was impossible to actually have amendments from all of the witnesses we heard from, because any witness that we heard from after probably like 2 p.m. on Friday, the ability to write the amendment, get it to the legislative clerks, then get it translated and get it off to the clerk was really pushing the bounds of what was and wasn't possible. If this government really cared about democracy, they would have extended the ability to have the deadline for amendments until today. Then we could have had the clause by clause tomorrow and been in a much better situation. But we're here because they've decided to ram this through, because they've been able to fail to plan to do anything that they've told Canadians they're going to do. This is a pattern of behavior from this NDP Liberal government where they continually tell Canadians that they're going to do something, they fail to do it, and then blame Canadians. And so I'm going to bring up the fact that this is not a pharmacare bill. I will join in some of the conversation of my other colleagues, but rather than continue to belabor the point, I will cede the floor, hope that we can have a swift vote on this and get to the rest of the amendments, because there are some amendments that I think are very important that we should have that will make this bill better, even though I don't think this is a very good bill to begin with. Thank you, Mr. Chair.
That exhausts the speakers list. Are we ready for the question? Shall CPC 9
Excuse
carry?
me, Chair. I'd like to request a recorded division.
Madam Clerk, CPC 9.
On CPC 9, Dr. Hanley.
Against.
Ms. Kayabaga.
Je vote contre.
Merci. Mr. Nakvi.
No.
Dr. Pulewski.
Against.
Ms. Sidhu.
Against.
Mr. Doherty. Mr. Ellis. Dr. Ellis.
Absolutely for.
Ms. Goodridge.
In favor.
Dr. Kitchen.
In favor.
Monsieur Blanchette-Jonca.
Contre.
Merci. Monsieur Julien.
No to the filibuster.
7 nays, 4 yeas.
CPC 9 is therefore defeated. How do people feel about a 10-minute health break? Any strong opposition to that?
Mr. Chair, if we
Yes.
have a 10-minute health break, I would ask that we extend the meeting by 10 minutes, considering we started late.
Very well. I'd ask the Vice Chair to take the chair, please. Thank you.
3, where are we at? Now, just so everyone's aware, as we just did amendment CPC 9, which was defeated. And now the next question is, shall clause 3 carry, is the question before us.
On division.
I don't see anybody opposing that on division. Everybody good with that? Yes, great, thank you very much. So clause 3 shall carry on division. We are now moving on to clause 4. There is an amendment, CPC 10. I certainly, I don't have my notes here in front of me. Just one second.
Mr. Chair,
CPC 10. Yes, please, Ms. Goodridge.
I would like to move CPC 11.
Okay, very good.
So the reason why I'm choosing to skip CPC 10 is we have actually already had the conversation on the verbiage when it came to the conversation around Indigenous peoples versus and Indigenous governing bodies, and therefore I would withdraw. Can we have unanimous consent to withdraw CPC
Excuse me,
10?
Ms. Goodridge, I don't believe there's a necessary to have unanimous consent if nobody moves that particular motion. So, that being said, that CPC 10 has been not moved at all. We'll move on to CPC 11. Ms. Goodridge.
Thank you, Mr. Chair. Sorry, I was just trying to save a little bit of time to get back some of the time that's been filibustered by the NDP members on this committee. I love that. At least he understands that what he's doing. Anyways, the amendment here is in clause 4 to be amended by replacing line 20 on page 3 with that it is more consistent across Canada in order to avoid a patchwork of care. Believe that it's absolutely important that we do address the inconsistency in coverage that already exists in the Canadian context, and this bill as it is currently written doesn't actually necessarily deal with that piece. And so this is part of the amendment that I think is a very common sense amendment, and I would urge all of my colleagues to vote in favor of it. This will strengthen the legislation and help remove the patchwork side. So, Mr. Chair.
Mr. Julian.
Thank you, Mr. Chair. I'll be voting against this amendment. What it actually does is it is in contradiction with the other CPC amendments that are intended to create that patchwork of care. And so I think the language that is in the bill is very clear, and we should hold to that. I'll be voting no on CPC 11.
Thank you very much, Mr. Julian. Mr. Nakvi, you have the floor.
Thank you, Chair. And we will be also voting against this motion because I think the language is fairly clear in the bill when it talks about consistency in Canada, and to me that's very clear from a statutory drafting perspective as to what is meant. And adding anything more to it, as being suggested, is really is redundant and doesn't add any more clarity whatsoever. So I think the way we see the wording is appropriate, and therefore there's no need for this amendment. Thank you.
Thank you very much, Mr. Nakvi. Ms. Goodridge.
Thank you, Mr. Chair. I do actually think that it is important to have, in order to avoid a patchwork of care, this is part of the problem that has been identified as we've heard witness testimony, and so it's a space where I appreciate that they want clarity. It's a 4-page pamphlet. It's not a pharmacare bill, as we've pointed out time, and we will probably continue pointing out time and time again. But I do think that showing Canadians that the intent is to avoid a patchwork of care is incumbent. But I guess if both the Liberals and NDP have already decided that they are comfortable having a patchwork of care, I guess they can vote against this amendment.
Thank you very much, Ms. Goodrich. Mr. Julian, you have the floor.
Thank you, Mr. Chair. Just to be very clear on this, there seems to be a contradiction between saying this is a pamphlet, but also Conservatives admitting that this is going to have a real impact on people's lives in a positive way. And so I note that contradiction. People who are watching this committee see that contradiction. That the reality is having this bill is going to make a difference in the lives of millions of people. And the language that is already in the bill is very clear in having consistent coverage across Canada, including the previous amendments that we have rejected. It is to keep the bill actually doing the effective work that the bill will do once it's passed by Parliament and the Senate, hopefully, and then moving from there to the Minister having negotiations with the provinces and territories. And so, for those reasons, I will vote no.
Mr. Julian, Mr. Doherty.
Well, let's be very clear. The reason why our colleague from the NDP is voting no is because he's been told from his coalition that this is the way that they want it, that's the way that he is to vote. With respect to any CPC amendment, it's the same old that we hear time and again when it comes to legislation that we've been told time and again in the House. The government tells you just let it get to committee and we'll work in good faith and amendments will be taken in and we'll work with great collaboration with all parties to get this bill right. Well, look where we are today. With a piece of legislation that really isn't, they're calling it pharmacare, really isn't pharmacare. This is the line that we're talking about so that Canadians are fully aware of what we're talking about here. So it is page 3, clause 4, subclause A, and the last sentence, in a manner that is more consistent across Canada. What is being proposed is that is more consistent across Canada in order to avoid a patchwork of care. If the whole argument that we hear from our colleagues down the way is that there are millions of Canadians that do not have, there are some that do have care and have programs and have access to medications, and that there are some Canadians that don't. Well, for me, it's a patchwork of care that we're experiencing, that Canadians are experiencing, which, if you want to believe what our colleagues are saying, that they are trying, that this bill is all about, C-64 is all about, is about making sure that we're eliminating the patchwork of care. Well, why not put that in the bill? No different than what we said earlier on, and we talk about the heart medication, that we have cardiac patients and constituents that have cardiac issues, and our colleague from the NDP has brought it up a number of times that his constituent faces $1,000 per month because of the patchwork of care that we have in our country. Yet he still didn't negotiate when he was sitting at the table with his coalition partners. Didn't negotiate to have cardiac medication in here, or heart medication in here. Another medication that was not, or another rare disease that was not, is not mentioned in this, and I don't believe it was mentioned in any of the testimony either, which is ALS. And the thousands of Canadians that struggle, that is inflicted with this horrible disease. It brings me to remembering one of my constituents who was struck down at the age of 28. He was a soldier within our Canadian Armed Forces, the best of the best, his commanding officer said. And at the age of 28, with his future right in his hands, Dean Gorsline was struck down, but with ALS. He lived the remainder of his life, much like my, bless you, much like my former employee, Brett Wilson, who passed away last August, after 9 months after his dad, Rick, was passed away from ALS as well. Both Rick Wilson and Dean Gorsline lived the remainders of their days after their diagnosis fighting for Canadians that were struck with ALS. Better people than myself. They turned their attention to ensure that that next Canadian that was diagnosed with ALS had access to those drugs that could prolong their life, that in the hopes that could walk back the impacts of that terrible disease. You know, we don't in this country have a rare disease strategy. And, you know, we talk about this National Pharmacare plan, what Bill C-64 or what our colleagues suggest that Bill C-64 is. And it does none of this. It doesn't provide greater access for those Canadians that are struggling with rare diseases such as ALS. You know, I think about that when we're talking about this bill. We're talking about you know, getting greater access, getting Canadians greater access due to the size of our country, and in some cases the comparatively small population that of Canadians that are inflicted with certain diseases. Canadians struggle to have access. Pharmaceutical companies will not look at Canada in a favorable way to provide access for the small groups of Canadians that are inflicted with such illnesses such as ALS. So they are forced to lobby. They are forced to do whatever they can, even though that their days are limited before this terrible disease takes over. It is absolutely horrific to see and watch. You know, I think about cancer patients within our country that this bill does nothing to talk about access to more medications and treatments. If it was a true pharmacare bill, wouldn't it, you know, again, we should have noted that. Maybe perhaps it would have been brought up. It's disappointing. This CPC 11 is a nonpartisan amendment that simply clarifies or adds to the line, and again I'll read it out in a manner that is more consistent across Canada. It simply adds, in order to avoid a patchwork of care, which is exactly what we're talking about, and which Mr. Julian's got his hands up, so he'll continue his NDP filibuster in the next little bit here. And he'll go on and on about how Conservatives are ragging the puck and filibustering this bill, but yet every chance he's on that speaker's list, Mr. Chair, speaking as much as Conservative members. So with that, Mr. Speaker, I will cede the floor so that we can get to the vote on CPC 11, unless Mr. Julian wants to continue his filibuster.
Mr. Julian, please.
Oh, okay.
floor, Mr. Julian.
Yep, I'm going to time myself because Conservatives are spreading a lot of disinformation. They talk for 15 minutes and somebody else talks for 20 seconds and they say, oh gosh, it's the other parties that are doing the filibuster. We all know who is blocking the bill and why 3.5 hours have passed at the cost of thousands of dollars. And we've only had votes on 2 amendments. I just wanted to flag one thing, Mr. Chair, and that is Bill C-213. If Mr. Doherty was right about wanting comprehensive, they don't want to have patchwork, they want a comprehensive pharmacare plan, my bill, C-213, 3 years ago and about 3 months ago, every Conservative, except for Ben Loeb, and I think Ben Loeb actually listened to his constituent, Ben Loeb, listened to his constituents. No other Conservative voted in favor of that. So I find the pretensions about a patchwork of care a little rich, given the Conservative track record. It took me 59 seconds to intervene, Mr. Speaker.
There are interventions with respect to CPC 11. If not, are we ready for the question?
I'll request a recorded division, please,
Recorded
Chair.
division on CPC 11, please.
C11, Dr. Hanley.
Against.
Madame Kayabaga. Merci. Mr. Nakvi.
No.
Dr. Pawlowski.
Against.
Ms. Sidhu.
Against.
Mr. Doherty. Dr. Ellis.
For.
Ms. Goodridge.
En faveur.
Dr. Kitchen.
For.
Monsieur Blanchette-Jonca.
Contre.
Mr. Julian.
No, contre.
7 nays, 4 yeas.
CPC 11 is therefore defeated. Brings us to CPC 12 in the name of Dr. Ellis. Would you like to move CPC 12, Dr. Ellis?
Oh, Chair, nothing would give me greater pleasure. So, you know, this amendment, CPC 12, and sorry, my notes are a bit mixed up since I was sitting in the chair in your absence.
And he is a physician, can't read his own handwriting.
Yeah, and I probably need to put my glasses on, which I don't want to do. But this amendment speaks about respecting the autonomy of Canada's highly trained healthcare practitioners. And this is exactly what I talked about here. And I find what I talked about previously, and I find it unusual as to why this actual clause in the first place might exist. So perhaps we'll start off by asking the experts why this might be a part of it. The appropriate use of pharmaceutical products in the original form, namely in a manner that prioritizes patient safety, optimizes health outcomes, and reinforces health system sustainability in order to improve the physical and mental health and well-being of Canadians, while respecting the autonomy of Canada's highly trained healthcare practitioners, and it goes on. So my question would be is, why do we need this particular paragraph in there anyway? Support the appropriate use of pharmaceutical products. Because when you begin to think about that, that would suggest that at the current time there is significant inappropriate use of pharmaceutical products. Now, I could make a bunch of assumptions that you're therefore against so-called safe supply, which in my mind would be the inappropriate use of pharmaceutical products, namely in a manner that prioritizes patient safety. Once again, that would allow me to believe that this NDP Liberal Costly Coalition doesn't believe that Canada's highly trained healthcare practitioners are practicing with the safety of Canadians in mind, or with the objective of optimizing health outcome. And of course, being good stewards of sadly, the health system, which is, in the words of one of the former presidents of the Canadian medical system, Catherine Smart, on the brink of collapse. So I'm not entirely sure, and maybe I'll start with Ms. Boudreau or Mr. McDonald as to what the conversations were with respect to the need to insert this paragraph. And I just need to reiterate it. It talks about prioritizing patient safety and optimizing health outcomes and reinforcing health system sustainability. And I guess my question then is, I know my question is this bill in this particular paragraph suggesting that that is not the case at the current time?
Sorry for the pause here. I'm just trying to find the exact spot.
I can provide that for you if you'd like. So it's on page 3. The paragraph I'm referencing is under Principles 4C as in Charlie. The amendment would be a line, adding a different line 29. Is that helpful?
Yes, thank you.
Great.
So you're quite, to point out, as you just did, it is part of the principles that the minister would be required to consider when moving forward on the National Universal Pharmacare. The others, A, B, C, and D. And then speaking specifically about appropriate use, one of the reasons that's there and is that there are numerous studies to show that, in fact, there are issues with improper prescribing or over-prescribing, and you're probably aware of a lot of efforts around de-prescribing, in particular with older patients. So the idea of the mention of appropriate use is to ensure the safety of patients, and it can also, when the right drug is given to the right patient at the right time, it can also have some savings both for the system and for the patient themselves. The other thing I'll just note is that the reference is also made in the context of the work that would be done by the CDA. So similar reference is made in Section 7 of the legislation. And then, of course, there's the work that would be done by the CDA to produce the appropriate use strategy. And then finally, just to close, I mentioned earlier that in working toward the CDA, there was the CDA Transition Office. And in part of that work, there's been a fair bit of work done already in the context of appropriate use strategy, and there will be a publication that's, sorry, there's a mosquito. There will be a publication of that recommendation from that expert committee very shortly. Thank you.
Well, that's absolutely fascinating to me, and certainly for Canadians listening at home, I would suggest to you that this is an absolute travesty to independent practitioners. And I guess I would like to implore my physician colleagues on this committee to make comments with respect to this. That is not to say that mistakes in medicine don't happen, that there is potential for inappropriate prescribing. But I guess what I would suggest is that I would love to hear their comments with respect to the government creating an agency which is then going to potentially monitor physician prescribing, the appropriate prescribing of medications, de-prescribing, which is not a new concept, and then to suggest that the government knows best with respect to what your physician should be prescribing or not. I mean, realistically, that's why doctors go to medical school, is to understand the right patient, the right drug, and the right diagnosis. Now, for all my physician colleagues out there, that's not always easy. This is an inexact science, and we know that even with long-term relationships with patients, appropriate examination and testing, that oftentimes the diagnosis still remains elusive, or certainly it's not in keeping with what the patient may like it to be, that specific diagnosis, or what it actually is, or you may actually lack the ability to access appropriate specialist consultation to come to the appropriate diagnosis, or the wait times, which I mentioned previously. And sadly, we have the longest wait times that we have had in Canada in recorded history in the last, since we've been keeping that time in the last 30 years. The wait time from seeing a family physician to seeing a specialist and obtaining specialist care is over 6 months. And so when we begin to hear this, that now we're going to have a government knows best approach, I wish I could interpret it differently. I can't. When I hear those things, and I want to take my parliamentarian hat off and put on a doctor hat and say, really, that I need the Canadian Drug Agency to talk to me about patient safety, outcomes, system sustainability, and an appropriate use strategy. I mean, when we begin to look at this and the incredible difficulty of how you might roll this out, this to me, it makes me not just want to add an amendment as is in CPC 12, respecting the autonomy of Canada's highly trained healthcare practitioners. What it makes me want to do is get rid of the entire paragraph. I mean, this is an affront to the autonomy of physicians, pharmacists, nurse practitioners, in the future, physicians' assistants, with respect to their training, to suggest that now we are going to have a government agency that is the intervener to say, well, maybe you don't know exactly what you're doing here, and we need the Canadian Drug Agency to talk to you about patient safety, health outcomes, and system sustainability. First of all, let's talk about patient safety. I can only imagine that, heaven forbid, I'm practicing as a physician, and my good friend and colleague, Mr. Doherty, comes into the office, and I have to wait for a memo from the Canadian Drug Agency to tell me what is appropriate to prescribe to him and what isn't. What did I go to school all those years for? The interaction between the patient and the physician coming to a mutually agreed upon diagnosis and treatment plan and follow-up and appropriate prescribing with respect to the contraindications, the indications, and the potential side effects is what is sacrosanct in medicine. That is what Canadians already expect. Now, if they're not getting that, and if that's the assertion here in this bill that Canadians are not getting that, and Ms. Boudreau, I want to reassure you that just because I'm looking in your direction, I'm not directing my ire at you. That's not the point here. I'm directing only in your direction, so I don't mean to make you feel that way. I direct my ire at the folks who created this ridiculous clause inside a bill to suggest that, as I stated earlier, we're talking about patient safety, to suggest that a prescriber doesn't have the appropriate abilities to understand the patient's safety associated with drug X, Y, or Z, and also to have that ability to appropriately understand the potential drug interactions and the monitoring and the potential side effects that is required. That is what prescribers go to school for. That's why physicians go to school. That's why you're there. The biggest tool that you have, besides being a good diagnostician as a physician, is related to the things you have in your toolbox, which would be related specifically, in the majority of cases, to medications. When you go to see a physician, oddly enough, historically, when no one else could prescribe medications, guess what you came out of the physician's office with? Anybody want to guess? Well, it's a prescription 85% of the time, because that's what makes, and still does, makes physicians unique. When you go to see the physician, you would like advice, you would like understanding, you would like explanation. And whether we like it or not, whether we want to admit it, we would like someone to fix the dang problem that we went in there with. If I went in with a sore big toe, I don't want to come out with a sore big toe and no plan to fix it. I want someone to say, this is what we're going to do about it. Through all my years of training and practice and experience and knowledge of you personally, that's what we're going to do. We have a plan. And if you're a primary care provider or a specialist, it doesn't matter. If you don't care enough as a Canadian trained and internationally trained physician or anybody who's a prescriber to know that there's a person behind what you're doing and that they have to be safe and trustworthy of your advice and your intervention and your prescribing, then my goodness, the last thing we need is a darn government agency trying to say, hey, well, you better reconsider what it is you're doing and what you're prescribing. My goodness, how cumbersome is that going to be? Just a minute, Mr. Doherty. I got to get the Canadian Drug Agency on the phone. I'll call the 1-800-WHO-CARES phone number, and they'll get back to me in 6 months. I mean, of course, I'm being facetious. I trust I'm being facetious. There's no plan within this pamphlet to suggest that I'm not. But that being said, the ridiculous nature of saying that we need an agency, and I'll come to the other points, first and foremost to talk about patient safety. If you have a prescriber in your life who's not primarily concerned about your safety, then you're in deep trouble. You will not be safe. It doesn't matter if we have a Canadian Drug Agency or a CDA, an LMNOP, a QRST, UVW, X, Y, and Z agency who's there to protect your safety. You're in deep trouble. Health outcomes. Now, health outcomes are incredibly important, but it all comes down to not necessarily just nationwide or countrywide health outcomes. It also comes down to your personal health outcomes. And if we're going to make an agency of the government of Canada, which is the most inefficient agency who can't, in this government, sadly, they can't issue passports, they can't pay their bills on time, they certainly can't manage inflation, they can't build houses, even though that we all know is not within the purview of the federal government. There's an inability to provide primary health care, as we've already talked about, to 7 to 10 million Canadians. There's an inability. Here we go. There's an inability to provide lab tests in a timely fashion.
Point of order for Mr. Julian.
We've now had votes on 3 amendments after 4 hours, and I would question the relevance again of Dr. Ellis.
Are you kidding me? This is ridiculous.
Dr. Ellis, please go ahead. We're talking about the autonomy of physicians, and that's what the amendment relates to.
Amen.
And I don't think we're very far off that. So go ahead, Dr. Ellis.
No, I mean, through you, Chair. This is talking about a significant change in how medical care is delivered in this country, and Mr. Julian thinks this is a joke. I am unsure of what his antics are to attempt to interrupt what we're talking about here. Maybe it's because he doesn't understand what it is to provide medical care. I don't think he needs to understand that, Chair. What I think he needs to understand is what it is to actually receive medical care. And if he doesn't understand that, I'm quite happy to provide him with a diatribe with respect to that. But if he does not believe, and Ms. Kayabaga, if you want to wave your hands and you don't think it's important either, this is ridiculous.
Please, Dr. Ellis and everyone else, direct your comments through the chair. The back and forth, the shots are uncalled for. Ms. Kaibaga, you don't have the floor. If you want to have the floor, you should put your hand up. And Dr. Ellis, please go ahead. But
you know what, Chair? I do apologize because this is something that no, I don't apologize for calling out Ms. Kayabaga. What I do apologize for is the passion with which I've approached this, because it is incredibly important on behalf of Canadians, and it's not humorous. It's not humorous. It is something that's incredibly important. And for anybody who doesn't want to choose to believe that, that's their own prerogative. And Chair, I would suggest to you that those who do not have the floor really should keep their peace. That being said, Chair, again, having a government agency that wants to be responsible for health outcomes on quote-unquote behalf of Canadians, when, as I mentioned previously, we know that the relationship between a primary care provider and that patient is sacrosanct in Canada, and that's something that Canadians are absolutely starving for. When we ask them what they would like to see in a healthcare system, what do we hear? They'd like to have a primary care provider because they trust that the training that that primary care provider has had will best represent their interests and create a relationship, and hopefully as a primary care provider over the long term, understand what the patient's goals are with respect to health outcomes, which leads me very clearly to understand here that there is no mention in this pharmacare bill of what the patients may want. This is, again, a costly coalition brought forward pharmacare pamphlet which does not mention that. Then there's two more points that we have to discuss here, is system sustainability. Once again, the best stewards of the healthcare system are those people who are working in it, not another government agency. I don't believe for 1 second that there are groups of primary care providers out there who, when they make a decision, whether it's a pharmacoeconomic decision about understanding the best, for example, ACE inhibitor to prescribe and the pharmacoeconomic advantages amongst ACE inhibitors and the studies that have been released over the last 30 years that encompasses all of them, or whether to choose to use, which the choice is naturally at this day and age made for a prescriber, to use generic medications, which appear at the current time to be reasonably good pharmacoeconomic decisions. Those are made often outside the purview of the prescriber, but certainly when we know that when there are untoward effects, there's a significant ability to allow a primary care provider to advocate on behalf of their patient to have the best health outcomes related to the best medications with the fewest side effects available at the current time. And that's something that certainly primary care providers have done from time immemorial to say that the system itself is part of the overall ecosystem in which primary care providers and specialists alike practice. Are there people out there who are willy-nilly ordering MRIs and CAT scans and unnecessary lab work? There's a few. I'm not going to sit here and tell you that there are not, but do I believe in any way, shape, or form that another government agency certainly from this costly coalition government, the most inefficient government and the government with the most inability to provide basic services to its citizens, should be the one who's now in charge of system sustainability and believing that primary care providers and specialists alike have absolutely no idea of what's going on or no responsibility to the system? That's a fallacy, and it's quite frankly it's an affront to prescribers out there everywhere, and more importantly, it's a big fat lie. Finally, on an appropriate use strategy, for the edification of those watching, and I hope not for my colleagues, physicians out there have to maintain a continuing medical education every year to ensure that they are able to continue to practice medicine in the most forward-looking fashion available. So again, it's another slap in the face to physicians, pharmacists, nurse practitioners, to talk about an appropriate use strategy, whether it be for medications or hospital beds, MRIs, CTs, ultrasounds, specialist consultation, et cetera. The practice of medicine is not some cookbook kind of thing that you do on your days off that you say, well, suddenly I think, I'm just going to be a doctor. Maybe I could whip out this book and look up the fact that maybe somebody has has syphilis or something like that, and say, hey, this is the test that I need to do, and knowing that Syphilis is now rampant in this country, and perhaps multi-drug resistant syphilis. That now we need to talk about an appropriate use strategy. I just don't believe that's true. That's why, if our primary care providers out there don't have a desire to understand the environment in which they practice and continue to get better, that is why we have those governing bodies in existence now. We don't need another legislative body to come out and say this is what we need. Is surely the Canadian Drug Agency will make sure that everything is going to be used appropriately. Surely the Canadian federal government will be the best arbiter of that. Again, I will close by saying this is a slap in the face to every highly trained healthcare practitioner out there, and it needs to be amended. Thank you.
Mr. Nakvi, please.
Thank you very much, Chair. I think what this clause is doing is ensuring that we put the well-being of patients front and center, and that's really what is central to this clause. And that sort of goes to the essence of the principle of appropriate use. I don't think this clause in any way is challenging the concept of physician autonomy, but what it's saying that at the center of everything that we do, we need to make sure that patient well-being is front and center, and sort of that primacy of patients by using language like health and well-being of Canadians is really at the core of this provision. And of course, we heard from Dr. Ellis, and love to hear from colleagues from the Liberal side as well, who are medical practitioners and have more experience than I would do on this particular area. But this is what my understanding is. It's really sort of looking at ensuring that in the Canadian healthcare system, the most important feature is the well-being of patient, to have a system that is patient-focused, patient-centric, and this is what this clause is trying to do. And in no way it is trying to take away from the autonomy of a physician, but making sure that Canadians' well-being remains centered to it, and that's why this provision is drafted in this way. And I suggest that we vote against the amendment because it dilutes the patient-centric aspect of it, which I think is critical. Thank you.
Thank you. Dr. Kitchen, please.
Thank you, Chair, and thank you for the opportunity to speak. It's interesting to hear the conversations that we've had today, and I recall on Friday when Canadians were sitting and listening to what was going on, and the short list of witnesses that we had, and who many of them had put forward recommendations that they would have liked to have seen being addressed and looked at. And as we were aware that at that time that the time frame was 4 o'clock for when they had to be in, and so a lot of them were not there. And so people and Canadians that are watching this are expecting that this committee look at those amendments and make some changes. And I said at the time that there's no way that this NDP Liberal government would ever accept any of the recommendations put forward, and they're just going to push through with what they're doing. And when we look at this amendment that's being put forward here, I'm a little shocked when I heard Ms. Boudreau when you said about appropriate use. And I'm wondering if you can clarify for me the meaning of what you said at that point in time on the issue of appropriate use of practitioners, suggesting that practitioners are providing medications inappropriately, providing medications without keeping track of it, et cetera. Could you clarify that, please? Sure.
The The idea of appropriate use is really, in the simplest terms, is the right medication, the right patient at the right time. So typically, for example, even now, physicians will look at practice guidelines often to decide which would be the best treatment. There is certainly the discussion and the patient and physician relationship, but the statistics are fairly consistent that in fact there is a good deal of overprescribing that occurs. So for example, with seniors in particular, there are statistics of as many as 2 million seniors reporting that they are taking medication that they inappropriately. And when that happens, you do have severe, often severe and certainly serious side effects. That then results in patients using up health system resources, going to hospitals, et cetera. So appropriate use is really intended to be a tool that would be used by the physician to do, as has been noted here, which is to work towards the best possible outcome for the patients. So it's another tool that would help physicians do that.
Thank you for that clarification. I find it shocking that in my years of practice, with all the professionals that I've practiced with, and your suggestion that they aren't trained and suggestion that they aren't doing that appropriate use is mind-boggling, because these practitioners, whether they be pharmacists, whether they be doctors, whether they be nurse practitioners, whether they be nurses that are providing those medications, your statements are suggesting that what this legislation was written up for was to give the minister the ability to regulate what that appropriate use is. And I find that extremely shocking, that we're sitting here with a piece of legislation to basically tell practitioners who should be paying attention to what's being done here that once again this government is coming after them for what they're doing and putting the power in the power of the minister to do that. This government came after practitioners that incorporated, and with the capital gains tax that they're now proposing changes to. Again, trying to attack professionals along those avenues. And here we see another attack at them. The great Paul Harvey said that self-government won't work without self-discipline. And self-government is what practitioners do. And they govern themselves. That's what regulatory bodies are there for. And they have those regulatory bodies. Each one of them have those bodies there to regulate and govern their professionals. And they have steps and procedures to deal with that. And you're saying that this legislation now is suggesting that you're going to take away that autonomous ability of those practitioners and put it in the hands of the minister to deal with this aspect of things. And I find that just appalling. My riding is Souris Moose Mountain, and the great city of Weyburn is in my riding. And the great city of Weyburn is home to Tommy Douglas. And many of his family are still in the community and are in the areas. And when the legislation came out in 1962, does anyone remember what happened right after that legislation came out in Saskatchewan? There was across the board doctors' strike. Why? Because people were attacking the professionals. The dental plan, again, that's being put forward by this government that suggests we're going to provide all this help for Canadians. And don't get me wrong, we need to have that health care. I'm 100% behind providing that dental care. But of those practitioners that are of the ones that the government and this Liberal NDP government keep talking about, hardly any of them, less than 1 to 2% are dentists. There are dental hygienists, but they're not dentists. And when you try to find a dentist, you can't find them. And you try and find a dentist in a rural community, there's almost impossible to find one. So for the statements that you're making here and clarification of what this piece of legislation says, and this in particular, this part 4, Section C, it is suggesting that if this goes through, that the professionals will be regulated by the Government of Canada, by the Minister of Health. And that's appalling. And I think Canadians that are watching this, and doctors and professionals, healthcare professionals, need to be aware of that they're losing their ability to self-govern. So I just find it appalling that where we wouldn't turn around and take a look at this simple piece of amendment to it to provide that and ensure that autonomy is there for the trained healthcare practitioners that provide that service. I just find it shocking that people would not support this piece of this amendment.
Dr. Hanley?
Thank you. I'm really happy to speak on this regard, especially at invitation of my friend and colleague, Dr. Ellis. Look, I haven't been intervening a lot in today's clause-by-clause debates because my constituents are asking me to support pharmacare and get this critical legislation passed. I do think, with all respect, there's a little bit of trust me, I'm a doctor, tone to what Dr. Ellis and colleagues have been saying. Of course, physicians practice with patients' best interests in mind. That's a given. We're all trained to do the best we can, as do the vast majority of health professionals in general, whether we're talking about OTs, nurses, pharmacists, lab techs, all the providers in the system. But we all contribute to a system where errors and overprescribing occur. I was thinking when my colleague quoted a great Dr. Harvey, there's another Dr. William Harvey who said, as art is a habit with reference to things to be done, so is science a habit in respect to things to be known. And I think we just have to look at a little bit of what the science is telling us. So, for instance, nearly 70% of Canadians over 65 take 5 or more medications. About 10% take 15 or more. And that's a recipe for a higher risk of harm, hospitalization, other reactions, injuries, potentially avoidable hospitalizations, and even deaths. And there are many, many studies and much evidence to document polypharmacy, overprescribing, and inappropriate use. It doesn't mean physicians aren't working hard or prescribing diligently, but mistakes do occur. And I think of this as a kind of a system. We need to, this is a system error or a way of errors, and we need system approaches. An example, there was a U of T program to provide tools to practitioners to recognize inappropriate medication use as a result of prescribing cascades. So in other words, you participate in a system where more and more medications potentially get added on to a patient's prescribing list, and no one really has the tools or the time or maybe not even the knowledge or to really take a look at de-risking and having that holistic approach to reducing the risk of adverse effects by re-examining the whole list of medications. Alberta even has an appropriate prescribing and medication use strategy for older Albertans. Most physicians, and I'm sure Dr. Ellis knows very well in practice, the Choosing Wisely program, of which the Canadian Medical Association is a strong partner in, which really is again looking at increasing physician knowledge in recognizing where there are common pitfalls, whether in the way we use diagnostic strategies or in prescribing. So further to all that body of evidence, I just don't see where it says that the minister or the CDA or the government is going to tell physicians what to do. What I see are principles, and really what the clause says is that the minister is to consider the following principles. I won't read the whole thing, it's before all of you, but specifically it says the minister will support the appropriate use of pharmaceutical products, namely in a manner that prioritizes patient safety, optimizes health outcomes, reinforces health system sustainability in order to improve the physical and mental health and well-being of Canadians. I don't know a physician that is not going to support that principle and that does not want to participate in a system that helps improve patient safety through rational and appropriate prescribing. So that's why I will not be supporting this amendment. Thank you.
Dr. Pawlowski?
Much in keeping with what Dr. Hanley says, I support the section as presently worded. I don't think it needs to be amended. I certainly do not think the purpose of this section is to establish bureaucracy, federal bureaucracy, to decide on what is and isn't appropriate prescribing of medications and pharmaceutical products. That kind of decision and judgment is rightfully left to institutions like the College of Physicians and Surgeons of the individual provinces, medical advisory committees, chiefs of staff, and chiefs of department. And again, I don't see this as any attempt to encroach on that jurisdiction or make those kind of decisions which are appropriately left to doctors, and there is appropriate oversight within the medical community. Again, as Dr. Hanley has suggested, these are things for the minister to consider when working towards implementing a national universal pharmacare. And certainly the minister and the whole system would want to certainly consider what is and isn't appropriate use of medications when setting up such a system, along with safety. And I would say I would put the emphasis on sustainability. And even those of us who've been practicing a medicine a long time, I think we all kind of learned as we were clerks and interns that we should always take the cheaper option when available. And I think similarly in setting up a national pharmacare system, if there's a choice between drug A and drug B and both of them work just as well, in order to make a more affordable system, which I think all Canadians want. We don't want to all be paying all our money in taxes. We want to be able to use the cheaper medication when they have equal outcomes. So again, although I do understand where the concern is coming from the Conservative Party, I do not see that as being the intention of this clause. Thanks.
Mr. Julian, please.
Thank you, Mr. Chair. I do note that Conservatives have squandered our time today. We've got over 4 hours now to vote on 3 amendments. I really regret that. This is one of the most important bills ever to come before the Health Committee. Certainly since universal health care was adopted in the 1960s because of Tommy Douglas, because of the work of the NDP in a minority parliament. And I'm really saddened that Conservatives have squandered 4 hours now of committee time at the cost of thousands of dollars to consider 3 amendments that seem to be not amendments really made in good faith either. If we're talking about patient safety, I'm almost tempted to ask our witnesses the number of Canadians that die every year because they can't afford to pay for the medication that their doctors prescribe. It would be a rhetorical question. The Canadian Federation of Nurses Union and the DeSilas already spoke to that. 600 Canadians die every single year because they can't afford to pay for their medication. So their doctors, in good faith, prescribe the medication. The patient leaves the doctor's office and can't afford to pay for it. And in every 2 days on average, we lose 3 Canadians because of that. 600 Canadians dying every year because of a lack of ability to pay for medication. So the pharmacare bill meets, at least to start as a first phase, the important need. When it comes to diabetes medication, it will save a couple hundred lives every year. And as it moves in phase 2 to heart medication and other types of medication, we're talking about many more lives being saved. So I would, through you, Mr. Chair, I would call on my Conservative colleagues to stop blocking the legislation, to stop filibustering tonight, to stop raising points that can be readily answered just by reading the legislation, readily answered just by understanding the dynamic that kills 600 Canadians a year because we don't have universal pharmacare in place. And that's why it's so important tonight to get through this legislation. Fortunately, the House of Commons had the presence of mind to think ahead and thought that Conservatives would filibuster, as they have. And that's why we will be able to complete the clause by clause tonight. And it's because of the House of Commons voting to say to this committee, you have to keep sitting until all the amendments are passed. But I would have preferred that the Conservatives would have allowed debate on the amendments rather than filibustering each one. And that would have allowed us actually to move through. We would be in the process of looking at the final few amendments at this point. That's not what happened tonight, and I regret that. This is too important for Conservatives to filibuster and block. I know the member from Carleton hates the idea that Canadians would be helped, but they will be helped because I think a majority of members around this committee table believe profoundly in stopping that horrible death rate of 600 Canadians a year.
Dr. Ellis?
Thanks very much, Chair. You know, it's interesting. I would never, ever suppose to know what is inside Mr. Julian's head, through you, Chair. And it fascinates me to no end that he would suppose to know what the member from Carleton thinks, that he doesn't think pharmacare should exist or that 600 people a year should die or anything like that. You know, that's utter nonsense. And, you know, when you want to talk about numbers of people dying, as I mentioned, you know, from people not being able to access the system in which this NDP Liberal coalition government promised 7,500 doctors, nurses, and nurse practitioners, which we all know is the purview of the provincial government, but they promised it nonetheless. That 17,000 to 30,000 people, because not all provinces report and territories reported the deaths, die every year because they can't access practitioners and/or services. So we have a system that is on the brink of collapse, and a system which Canadians questioningly, and appropriately, questioningly should trust the NDP Liberal coalition to create another system, which is quite fascinating to me, to suggest that we need this national system simply to protect the NDP Liberal costly coalition. Everybody in Canada knows that that is the only reason this piece of legislation has reached the floor of the House of Commons. Everybody in Canada knows that the coalition is what has caused pharmacare to come to the floor of the House of Commons. Now, Mr. Julian might say this is his, greatest crowning achievement, et cetera, the most important thing since Tommy Douglas created pharmacare, all those things. But what we know is that Canadians want a functioning healthcare system first and foremost. So that's the counter to his argument, and to suggest again that Canadians, the Conservatives on behalf of Canadians are mounting a specific and robust opposition to what the costly coalition has provided to Canadians over the last 9 years, which is a doubling of rent, a doubling of mortgage, the fastest rate of interest rate increase in 40 years, the greatest amount added to Canada's debt in the entire history of the country. And to say that that is something that then we should entrust them with very specific and other far-reaching bills is, in my mind, hogwash. Back to the fact of talking about the autonomy of physicians. On behalf of Canadians, I wish that I could share Dr. Pawlowski and Dr. Hanley's, again, through you, Chair, I don't want to say something disparaging, but that their ability to forego rigorous scientific examination of what the government has done already in the past, that we should just simply trust them. Now, of course, they're part of the government. They're part of the costly coalition. Doesn't matter how much I like them. They're still a part of it. And if you want to be in French, a béni oui oui, and just suggest that everything is good and shake your head yes, then you can continue to do that. That is the prerogative, of course, of members of Parliament. But when we know that, if there's no nefarious purpose, then why would this particular paragraph outline under the principles that suggests the ministers to consider the following principles? And this is what they can do. This is the power that the minister specifically